Hello, everyone, and thank you for joining us today. Welcome to NCSL's webinar on state efforts for testing and contact tracing for the COVID-19 pandemic. My name is Tara Johnson, and I will be moderating the webinar today. I direct our public health and maternal and child health work here at NCSL in NCSL's health program. The spread of the coronavirus continues to be a top concern for Americans, federal, state, and local government, and increasingly state lawmakers. Policymakers are taking extra steps to respond to and anticipate impacts of the virus. NCSL is committed to providing our members with timely responses to state research requests and the essential knowledge needed to guide state action. This webinar is intended to educate state lawmakers on response to the coronavirus, specifically around testing and contact tracing, as well as provide you with resources as you navigate this ever-changing and unprecedented situation. Today's webinar is a platform for informational exchange and engagement. Over the next 60 minutes, we will encourage participation through the chat box, so please feel free to type your questions and answer any questions in the chat box in the lower left-hand corner of your screen. I want to briefly mention the resources. Above this presentation, you will see tabs with one of them labeled Resources. Here you can find and download a PDF of the PowerPoint, as well as find several resources NCSL staff put together for you. Another tab is labeled Speaker, where you can read the bios of today's speakers. You can access these tabs at any time during the presentation. Today's webinar is being recorded and will be available on NCSL's website within the week. The National Conference of State Legislatures is a bipartisan organization that serves legislators and legislative staff of the states, commonwealths, and territories. NCSL provides research, technical assistance, and opportunities for policymakers to exchange ideas on the most pressing state issues and is an effective and respected advocate for the interests of states in the American federal system. NCSL does not advocate for specific policies, nor do we take positions on state issues. This webinar is a platform for information exchange. We hope that this webinar will help answer questions. NCSL developed a webpage to house our comprehensive resources on state and federal response to COVID-19. You can access this webpage through the resources section or just go to ncsl.org and it will pop up. Here you can find information on state policies and response related to continuity of government, education, fiscal elections, criminal justice, and other important considerations. For the webinar today, we have 4 extraordinary speakers who will share their public health and workforce expertise with us. Please remember to click on the speaker tab to read bios. First, we'll hear from Dr. Nirav Shah, who will provide us with an up-to-date national overview on responding to the pandemic, specifically around COVID-19 testing and contact tracing. Then we'll hear from NCSL workforce expert Iris Hentz about several examples of how states are being creative to bolster their contact tracing workforce. Then we'll hear from Indiana State Health Commissioner, Dr. Christina Bach, and the Commissioner of the Massachusetts Department of Public Health, Dr. Monica Burrell, who will share their state approaches to mitigating the spread of COVID-19. To kick this off, I will highlight the state legislative responses and provide several state examples. Related to COVID-19 testing, at least 15 states and the District of Columbia have introduced more than 50 bills related to carrying out COVID-19 testing, and this is not including insurance coverage, liability, or data collection. At least 12 measures have been enacted or adopted across 10 states and the District of Columbia. Many enacted bills provide funds to support state testing. Minnesota, for example, appropriated funds for COVID-19 activities, including the establishment and operation of temporary sites to provide testing services, and for the development and implementation of screening and testing procedures. Other bills have to do with establishing a protocol or a task force or commission on testing. For example, Utah created a commission to advise and make recommendations to the governor regarding the state's response, including a plan to promote widespread testing. Many introduced bills require certain populations to be tested or prioritized in testing. For example, first responders or nursing home residents or staff. Related to contact tracing, At least 35 bills have been introduced across the states to coordinate or fund contact tracing or to require related privacy protections. At least 9 of these measures have been enacted or adopted across 7 states and the District of Columbia. For example, a law enacted in Illinois includes $200 million for costs and administrative expenses associated with contact tracing and testing. Some bills focus on coordinating contact tracing, such as bills in New York and in South Carolina, which have language requiring contact tracers to be representative of the community or hired through community partnerships. We're also starting to see bills which concern privacy protections around data collection through contact tracing, such as a law recently enacted in Kansas. If you'd like to learn more about bills introduced or enacted on testing or contact tracing, please see the memos provided in the resource section. Now I'd like to introduce Dr. Nirav Shah, a physician and senior scholar at Stanford University School of Medicine. He's a world-renowned expert on COVID-19. He will provide a national overview and an update on testing and contact tracing. Dr. Shah does need to hop off in about 25 minutes, so please remember to write your questions in the chat bar during his presentation. Welcome, Dr. Shah.
Thank you so much for that kind introduction. And after these disclosures, I'd just like to jump right into the content. There's some great content. We have a lot to cover. So as you know, there's a lot of different strategies out there on what are we doing with COVID. And you've heard of New Zealand's success with a total containment and elimination strategy. Other countries like Taiwan and South Korea and Germany and others have tried that and have met with varying levels of success. Then there's a herd immunity strategy, which is the other end of the spectrum. Basically, let the virus spread until everyone is affected. 60 to 70% of the population is affected means it'll eventually die out. And so Sweden and Brazil are 2 examples of a herd immunity approach with, again, varying levels of success and implications in terms of who's dying, who's affected. And then there's something else, and I would count us in the something else bucket as a nation because we don't have clear pathways toward elimination or herd immunity, and it's a de facto herd immunity in most states across America where we're trying to balance lives and livelihoods. Just a point of fact, the death rate from COVID for an average 30-year-old to an average 80-year-old is a 300-fold difference. From a baby to an 80-year-old, it's about a 10,000-fold difference in risk of dying. And so we have to think, and I hope that over the next few weeks, we really start to think about a risk-stratified approach toward COVID rather than a one-size-fits-all. So some of the things that you may want to follow closely in your county, state, region are these metrics. And I wanted to give you some data points for where to find them and how you might be able to use them. And let's start with the very first data point, which you've heard of variously called R0 or RT. It is the infectiousness of COVID in your community. It relies on how many people are immune, how many people are affected, what kind of masks or shelter in place or non-pharmaceutical interventions are in place. And at the end of the day, the RT is a measure of how infectious, how many people are getting COVID from one known case. So if an RT is 2, that means for every case, 2 people will be infected. If an RT is 0.5, then for every person who's infected, they'll infect on average half a person, which means that you're dying down with COVID. This is an example from covidactnow.org, a nonpartisan evidence-based organization that collects the best available data from Johns Hopkins and every other site and puts it into a very usable format. I'm an unpaid advisor to this, and I tend to go to this site because it has some of the best user experience and interfaces down to the county level for most of America. And this is where I am at Palo Alto, and you can see our R0 has been hovering around 1 or 1.02 currently. And that means it's still spreading. We're not actually reducing the spread of COVID in our county. It is, on average, spreading a little bit positive. To give everyone an anchor point, for Wuhan, when they finally saw real elimination, they were down to an RT of approximately 0.3. The next priority during our current reopen safely phase is our hospital or health system capacity. And there are several ways to look at it. Are your ICUs full? Have you hit critical mass? Another metric is, are less than half of the hospital beds occupied by COVID patients? Between the percent of ICU fill and the less than 50% of hospital beds filled by COVID patients, those are good measures of how much spare capacity you have for COVID patients in your community. Testing capacity we'll go into some more deeply. And this is confusing because when we hear about tests, we hear about many different kinds of tests. And sometimes they are conflated. So the most widespread tests are those PCR nasal swabs and now the emerging saliva tests. These are tests of the actual virus itself. When they take that nasal swab, they see, do they have the RNA of the virus? These usually take a few hours turnaround time minimum. You may have heard of like the Abbott Rapid Tester, which has a 15-minute turnaround, but doesn't really work very well. And so we're still relying on slower tests that are more expensive and take time for the vast majority of our testing. Now, you've also heard about antibody tests or serology, blood tests. What those are measures of our immune response to the virus. By the way, all these slides will be available. Every slide has its citation. And so the serology tests are some measure of how are we approaching herd immunity. For example, you may have heard of serology tests in New York City suggesting that 15–20% of people may have antibodies, which means 15 or 20% of the population has been exposed to COVID at some level and theoretically have some level of immunity. We don't know, but we think that they have, like with other viruses, antibodies suggest some level of protection, not forever, but from the strain of COVID they were exposed to. So it's not a free pass that you have antibodies that you can walk around and say, I'm immune from COVID. It's really a measure of you might be safe from some strains of COVID for some time, but more likely the fact is you were exposed to COVID and your body has created an immune reaction to it. So sometimes we confuse the two. Sometimes we add both up and say this is how many positive tests we have. The reality is you should really be focusing and talking about the PCR tests, vast majority of which are nasal swabs. Now the new saliva tests are coming out that are very good. Among the tests, you can see there's about 127 PCR tests. There's 155 serologic tests. And there are other tests that are being developed, but the vast majority are the serologic and the PCR. Both of those have very wide variability in terms of how accurate they are. And so you should know something about the sensitivity, specificity of a test. If you're in a place where there's very low rates of COVID and your tests come back positive, that half the time, even though you have a positive test, that PCR test will be wrong because of how the math works out. And so oftentimes you'll see people are tested twice if they have a positive test. And the same in terms of a negative test isn't 100% that you're safe from COVID. It relies on the test characteristics. So be careful in interpreting it. If you're getting a test, make sure your doctor or someone explains it to you in terms of how good it is for positive predictive value and other of those metrics. Now, in America, what we started with in early March was testing of only those with strong symptoms. And now we're starting to test more and more people down this pyramid and adding people to the testing. When you add more people to the percent of the population being tested, the percent of those tests that come back positive decreases. So we're talking here about PCR tests. We're talking about the percent of positives. If you're testing broadly, you should have fewer than 3% of your tests coming back positive. That means you're testing a whole bunch of people who don't have symptoms, you're testing broadly in the community, and your rate of testing is so good that it's under 3%. You can see the countries like New Zealand, South Korea, all in the bottom left green circle are those that have tested broadly and are maintaining a less than 3% positivity rate. This is an example from North Carolina. Their current test positivity rate is hovering around 7%, which is okay. You know, we want to get to under 3%. That means they need to expand their testing to get to the 3% or lower rate. The more tests you do among asymptomatic people and more broadly, the lower that rate will be, and good is in the green in the bottom when it comes to positive test rate. Very few places in America today have sufficient testing capacity to reach that 3% level and stay there. So just this is a very important point. We have to test broadly before we think about tracing. If you're not testing broadly enough, you're not going to be effective in tracing. So let's turn to tracing. So we know that most folks, this is an older graph that shows that a lot of the transmission is happening from people who don't have symptoms, don't know they have COVID, or have symptoms but haven't expressed their symptoms to the healthcare delivery system. When you're seeing it in the news, people are asymptomatic. All that means, that asymptomatic means they haven't shown up to a doctor and told them about their symptoms. They may have symptoms, but for our classification purposes, they've been called asymptomatic. We know that more than half of transmission happens from people indoors among family members or close contacts of people in nursing homes, for example, who are indoors and without symptoms. And that's why the masks and the social distancing and other suggestions. Now, let's talk about contact tracing for a minute. Contact tracers do their job by reaching out to a positive case and asking, who did you have contact with in the last week or two that we can reach out to? And contact tracers need to reach out and talk to all of the person's positive contacts within 48 hours. Well, on average, it takes about 5 contact tracers for every positive case to get to a 48-hour turnaround time and to reach out to all of the potential contacts of a positive case. In America, Hopkins and others have suggested that we need over 100,000 people trained as contact tracers. This is also exquisitely dependent on how many positive tests we have. If we're not testing broadly, if we're not catching all the cases, then contact tracing doesn't make much sense. So think of it as sequential, that we need to have aggressive testing and then we need to have aggressive tracing to really tamp down the disease. And when you're tracing, what you're doing is after testing widely, number one, then you find folks and say, please self-isolate for 2 weeks. And among those people who are positive and get tested among the isolates, you're also going back and tracing their contacts as well. And then ultimately we'll repeat the cycle. This is from Tom Frieden, former head of the CDC, who calls it a box-it-in strategy. So this is an example from Wisconsin. This is a few days old. Wisconsin has about 480 contact tracers with about 291 daily cases. They need about 1,500 contact tracers to trace everyone within 48 hours. And these are numbers that are to the best of our ability. We're catching, what's publicly reported. Some of these may be out of date, but so you have some sense of how many contact tracers we need. You want to hit 90% of all of a positive case's contacts within 48 hours to be considered good. So where does this leave us? Most experts think that in America we will see scenario 2, which is the second scenario, another big peak in the fall as people go indoors and as flu season ramps up again. Again, all of this we want to be proved wrong by wearing masks, washing hands, and all the non-pharmaceutical interventions. But if you have time to plan, you should plan for some sort of a second surge, whether it's a fall peak, as in scenario 2, or an earlier peak, as in scenario 3. Finally, you want to measure the effectiveness of your interventions. This is data from Apple Mobility Trends, which I like. There's many websites, including Unicast, Mobility Trends, and others reporting this data publicly. It shows that in America, we definitely have COVID fatigue, and that people are going above what baseline is, above what our historical trends are in terms of mobility. This is based on Apple searches in your phone for where you want to go. and visit. That's based on and comparing it for several countries. Another example that I wanted to point out is healthweather.us. This has data down to the county level for most of America, where you can see using a network of 1.5 million smart thermometers, basically thermometers hooked up via Bluetooth to smartphones, where is atypical fever occurring in this country. Atypical means you subtract out, you see what fevers are happening in a given city, you subtract out what you expect to happen from the flu and coughs and colds, and what's left behind is atypical. That is oftentimes COVID in the community. And in fact, they did studies and showed that when restaurants and bars were closed in Miami-Dade, very quickly the curves dropped off for atypical fever, and similarly in Santa Clara and elsewhere across the country. In fact, this is their recent data from New York City showing that their fever prediction curves, the blue line is the thermometer network from KINSA, the red is the actual deaths in New York City hospitals, preceded deaths by about 18 days. So it's a leading indicator of COVID in the community, and it's available for free at healthweather.us. I'll stop there and leave time for questions. Thank you.
Excellent. Thank you, Dr. Shah, for that great presentation. And again, I know you need to hop off in just a few minutes, so I do see a question from the audience in the chat box, which says, how can contact tracing be done if people are going to bars where strangers may be infected?
Yeah, so contact tracing is very hard to do, and so it does require knowing and following up aggressively with all of the known contacts, hitting 90% of actual contacts within 48 hours. So it cannot be done when you have strangers you don't know, where you don't have 100% compliance. You know, the apps that Apple and Google have released for contact tracing, we need high levels. We need over 60, 70% of people to opt in and use it and turn it on to even have a small dent in the number of contacts that need to be traced. So it's interesting that we're having this conversation around contact tracing when the reality in America is today, almost everywhere in America, we don't have enough testing in place, much less to be able to contact trace successfully, except in very few spaces and locations around America.
Mm-hmm. Great. Thank you for answering that. And I think this next question piggybacks off of it a bit. Dr. Shah, are you seeing any best practices from states related to testing or contact tracing?
Yes, I am. And I think what I'll highlight is that it starts with communication and understanding of the public on how they have a role to play in what they're doing. So, for example, the open communications we've seen in some communities about what is a person's risk, how they can help others, how they can stay safe for themselves, their families. That communication is the best practice I would start with. On top of that, you add in broad, freely available testing that's open to the public, as it is in many parts of where I live. That allows you to hit that 3% or lower rate of positive tests, where people are getting tested frequently. Ultimately, we'll have some very novel ways of testing. For example, if you don't have enough tests, they are suggesting that you have 50 people spit into a cup and you do one test across those 50. With the new saliva tests that are pretty good, that's a good way of getting mass testing done. And then, of course, obviously, if that pooled sample of 50 is positive, then you have to do follow-up testing in smaller batches to find out. But instead of doing 50 individual tests, you suddenly have tested 50 people negative. That's a very powerful way. So there are many thoughtful ways of getting testing up to scale. Let's say you're in a building, office building, the second floor, you test everyone who walks in at 9 a.m. With that mass saliva test. If it's positive, you send everyone home by noon. And then you do the deep cleaning, and you shut down that office, that second floor for a week. There's lots of thoughtful best practices out there, both for businesses reopening and at the county and state level in terms of getting testing up to scale.
Great. Thank you for those examples. That's really interesting and a different way to look at it. And there are two more questions in the chat box here for you. The first one is that you mentioned in your in your presentation about the severity of the virus in relation to age, and you also mentioned that we should target our strategies. Can you elaborate on that more?
Yes, we know that over 40% of deaths, and likely much higher when the actual counts come in from all of the nursing homes, over 40% of deaths have been limited to nursing homes and people who are older and have one or more chronic conditions. If that's the case, and we're starting to get now treatments, today a report out of the UK and Oxford suggested that steroids, simple steroids, dexamethasone, can cut the death rate for people who are on ventilators for COVID by a third to a half. Now that we're starting to get glimmers of hope among the treatments, while we don't have a vaccine in place for a long time, we still know that we shouldn't have a one-size-fits-all, that our highest risk, most vulnerable people are those in nursing homes, are older adults over 60, 65 with one or more chronic conditions, or younger with immune systems that are not as strong. What can we do to support them from social isolation and keep them safe? Because that is a part of the population that is highest risk. If you're young, if you're healthy, for example, Taiwan didn't even shut down their schools except for one school in the whole country for 2 weeks. And they didn't have any deaths among those school children. So we know that our one-size-fits-all has done a disservice to our economy because we didn't know any better. Now that we know better, it's incumbent on all of us to double down on the resources, including adequate PPE and protections for our nursing home residents. Today, nursing home deaths mirror the rate of COVID in the community across America. That's the best measure of how many people are going to die in a nursing home, is how many people have COVID in the community, because it's those workers who are going into nursing homes and spreading it. We need to solve that today so that we keep our vulnerable elders safe, and that way return to some more sense of normalcy. I'll add a point about vaccines. We do not have any hope for any reasonable vaccine for at least a year. The vaccines that come out in December, January are the first round of vaccines. They always, in every vaccine that we've ever developed, are not as effective as subsequent vaccines, and they will be available in very limited quantities. So we cannot count on vaccines to save us in December. We should wait for at least a year from now before we have better vaccines that are available in wide enough dosages to make a difference toward herd immunity. So think about, you have time to plan before the second surge. I would suggest people revise all the plans, think about protecting our most vulnerable neighbors, and approach it with a different approach than we did the first round, when we didn't have any tools in our toolbox except shelter in place and a mass lockdown.
Great, thank you, Dr. Shah. And I know you do need to hop off in a minute. There's a few more questions in the chat box. Do you have time for maybe one more, or we can collect these and send them to you? Okay, great. So the two questions, one relates to contact tracing, and some folks are not comfortable sharing close contacts with a stranger on the phone. They're interested in how other countries may have been more successful with participation rates. And the other question is, what is the role of digital contact tracing? Are there best practices for implementing both techniques? Just in case the answer, you might be able to answer both of those.
That's right. So quickly, so digital contact tracing is being used in some parts of America, where if you're working for a company, maybe they can mandate that you use digital contact tracing, an app on your phone, while you're in the office, so that should any person eventually turn out positive, they have a perfect picture of who they exposed, where they were, all of that, and thereby protect the workplace instead of shutting down the whole company. So that's one thing that I think is a best practice that's actually feasible in America, in the workplace, where people are in factories or otherwise in close contact with other people. Mass contact tracing by the apps is TBD. I don't see any real path for us unless 60% of Americans opt in or greater. So we shouldn't hang our hat on it. Maybe we'll turn around in some places and be able to do that, but we're still relying on analog contact tracing. Other countries that have succeeded have done digital contact tracing with everyone. You have to opt in kind of approach, or you get massive fines. Only then have they been actually successful with digital contact tracing in the broader population. I'll log off there, and I'll be happy to answer questions offline. Thank you.
Excellent. Thank you, Dr. Shah. Thank you so much for joining us today. We will move on to our next speaker. I do want to also make a plug. NCSL, I believe next week, is publishing a blog on COVID-19 in nursing homes as well. So be sure to keep a lookout for that blog, and we'll be sharing more information on that topic. So next we have Iris Hentz, who is going to talk about state workforce approaches related to contact tracing. Iris, I'll hand it over to you.
Thanks, Tara. So now that we've heard about the importance of contact tracers and best practices for helping states keep a handle on the pandemic, I'm going to take just a few minutes to cover the different approaches we're seeing states take to really ramp up their contact tracing workforces. I'd like to quickly note that, as Dr. Shah said, before deciding how to hire contact tracers, states have to decide how many contact tracers they need to adequately respond to the pandemic. George Washington University, in partnership with the Association of State and Territorial Health Officials and the National Association of City and County Health Officials, have published a contact tracing workforce estimator tool, a screenshot of which you can see on this slide. The tool helps estimate the number of contact tracers needed in a state based on population, the number of COVID-19 cases in that state, and its existing public health workforce. On the map, the states that are in darker color are projected to need more contact tracers per 100,000 people. So once a state decides how many contact tracers they need, there are a couple different approaches we're seeing states take to get these workers on board. Hiring new workers is the first approach we're seeing from states. Some states are hiring workers for contact tracing positions just like they would hire any other state employees. Another approach we're seeing states take is retraining existing state and local government employees to assist with contact tracing efforts. Finally, we're also seeing states recruit college students and volunteers from existing public service programs to serve as contact tracers. So now let's take a deeper look at some state examples for each of these approaches. Massachusetts was the first state to hire a large number of contact tracers. Back in April, the state partnered with the local health nonprofit, Partners in Health, to hire and train 1,000 workers to do contact tracing in the state. According to reports from NBC News, more than 9,000 folks applied in the first 24 hours for the open positions that pay between $20 and $25 an hour. The state currently employs about 1,500 contact tracers through this partnership, and they have signaled that they intend to continue hiring. We'll hear more about Massachusetts' experience later on in this webinar. Ohio is an example of another state pursuing a similar strategy. They're also working with the nonprofit Partners in Health to hire and train hundreds of contact tracing workers who will assist local health departments across the state with their contact tracing needs. In total, the state hopes to hire about 1,700 part-time workers over the next 12 months. Washington State, the site of one of the earliest COVID-19 outbreaks in the U.S., has hired about 1,300 contact tracers, including 351 workers from the National Guard. The state has also reallocated some of its other employees to contact tracing, including 390 from the state's Department of Licensing and 630 from state and local health departments. The state has also announced that it plans to hire more tracers in the coming weeks to help with contact tracing for existing employees. New Mexico is pursuing a similar strategy, currently relying on state employees who normally work in other public health roles in the Department of Health to conduct contact tracing. New Mexico has also partnered with health consulting company Accenture to help manage hiring of new workers to assist existing employees. The state is currently accepting applications for around 200 contact tracing positions. Finally, states are also recruiting students and volunteers to help with contact tracing. New Jersey has just announced its plan to train college students from Rutgers to help out with contact tracing. So far, the state has been relying on local health departments to recruit volunteers to serve as tracers or to train their own employees. The students are beginning a training program this summer that will include cultural competency training, so they will not only be able to trace COVID-19 cases, but they'll also be able to be responsive to the specific needs of diverse communities in the state. Other states are drawing from existing public service programs to recruit volunteers to become contact tracers. Colorado is beefing up their contact tracing workforce by tapping members of the AmeriCorps and Senior Corps programs. The state has been relying heavily on local health departments to build their own contact tracing staff, with about 300 contact tracers estimated to be working across the state in May. By partnering with AmeriCorps and Senior Corps, 300 more contact tracers will be ready to assist the state immediately in June, while another 500 will be recruited through an application process. And that's all for my quick presentation on the workforce side of the contact tracing puzzle. I'll go ahead and kick it back over to Tara.
Excellent. Thank you so much, Iris, for your presentation. Our next presenter is Dr. Christina Box, State Health Commissioner in Indiana. Dr. Box brings years of experience from being a practicing obstetrician and gynecologist and many years of leading the state health agency. As a reminder, her bio and all of the speakers' bios are available under the speaker tab on your screen. And I do see several questions coming through the chat box. We will address those after we hear from Dr. Box and Dr. Burrell. Dr. Box, welcome.
Thank you so much, Tara. I'm going to launch right into this. Early on, every state like Indiana suffered from the ability to not be able to test as many individuals as we needed to. We just didn't have the testing materials or the kits to be able to do that. So we partnered with a private company here at Eli Lilly, and we're able to vastly expand our testing capacities and are continuing to do that. Like many states, we didn't start to open back up until we're sure we had the capacity to test every Hoosier who is symptomatic and more. Like many states, we have labs that have had equipment to run these tests for the SARS-CoV-2 virus, but they just have not had the reagents. This is why Indiana developed a public-private partnership in the state of Indiana with the Hospital Association and Lilly, and has been able to bulk buy our reagents as a state, along with our testing kits and supplies that we need as a state, and then we will be distributing those to our labs at cost. We're also using this team to purchase, through our CARES dollars, different machines for labs throughout the state to make sure that we are establishing diversification in our testing platforms to be able to prepare for the future in case there's a chokehold on one particular set of reagents or materials. Many of our healthcare providers are now providing testing, but the State Department of Health has also taken on the role of a direct service provider by forming strike teams, and we have been hosting drive-through clinics and walk-up clinics and targeting our high-risk communities across the state this way. Our strike teams are one in each of our 10 preparedness districts, and an additional strike team available includes not only individuals who can do the testing, but also includes interventionists, infection specialists, and a nurse surveyor, and other individuals that can go into, for instance, our long-term care facilities, our meatpacking plants, and help to review plans and improve infection control. We've also worked with other congregate settings like our behavioral health settings, and our new ELC grant money we will be using to help expand subject matter experts and support for infection control for our K through 12 and our institutes of higher education. We will be using drive-through and walk-up clinics continuing in our high-risk clinics with the African American population and our Latino and Amish populations. Over 12,000 tests have been done this way, and 50% of those have been in African American places. We will continue to do these Wednesday through Sunday to ensure the weekend access. We also have statewide testing sites, which we've opened up with Optum Serve. There are 50 fixed and mobile sites across the state that is doing free testing. And we may start insurance billing in the near future, but that still remains to be seen. We are maintaining the ability to run for free these tests regardless of where we do insurance billing or not for individuals that are underserved or uninsured. We're using this capability now to test our long-term care facilities, all 57,000 employees across the state in over 530 facilities, and that will be concluded by the end of June. And we do maintain an actual web testing site for people to go to so they can determine where all the testing is available. When we look at the localized approach that we have used in Indiana prior to this with our 94 local health departments doing their own contact tracing, we've now consolidated that where we have a combined approach with the contact tracing, much of it being done at the local level, but a big percentage of that now being done in a centralized system here in the state. Governor Holcomb announced this approach on May the 4th, and we at that time started centralized COVID-19 tracing with the key principle to reopening the state. That was one of our main things. We had an incredible number of people express interest. The goal was to be able to hire 500 people within 30 days, and we actually have hired within 30 days 600 people and trained them. And we had very high-level individuals with degrees, physicians, nurses, a lot of professionals that applied for this. In addition to this, we have a pool of greater than 5,000 people that are waiting to be trained and hired if needed. We are also continuing to use the local contact tracing at the local health department level, which I'll expand on in a minute. We've partnered with Maximus, which is a robust call center that we were already using at the state level, and we use their customer relationship management tool, or CRM, and it is a Microsoft Dynamics tool. This helps us to integrate our disease surveillance system, which brings our labs in and automatically reports these cases to our local health departments and to our centralized contact tracing. You can see here the map that we maintain on our website of all the testing sites, and if you hover over any of them, you can see their hours and whether an order is required and what the testing they do. Our call center does the initial interviews here at the state level and case investigations. Every positive case receives an email and an SMS text asking the individual to call a specific number identified as the Indiana State Department of Health. If that individual has not called within 4 hours, we begin to call. There's actually a trigger that triggers the case to call queue, and we begin to call that individual. If we get no response by that evening, we send a no response letter out to these individuals to try to recruit them. And when the individual responds, we'll then do the case investigation and obtain those contacts. Positive individuals will receive a daily text asking about their symptoms and how they're doing for the next 14 days. And then when that case is completed, we can update that case. With regards to our close contacts that are identified, each contact will receive an SMS text message to fill out questions online. And if they need to be quarantined, based on that evaluation, we can send them a daily text or email to monitor their symptoms in case they develop any symptoms and make sure that they get in and are tested for COVID-19. And then if they're positive, obviously become a case. We do provide them information through email and on our website about quarantine and what isolation looks like. If a close contact fails to complete the questionnaire in its specified time frame, we actually are using calls also to reach out to those individuals. And we are able to flag our local health department for several things. One of those is those individuals that we're having difficulty reaching. Individuals that are in a long-term care facility or in a higher risk profession, we flag our local health departments. We flag them if there is a social determinant of health need. For instance, they need to have someone do grocery shopping for them or get pharmaceuticals, or they need transportation for health care. We still are relying heavily on those 94 local health departments to engage and be those boots on the ground as we go forward and do these investigations. This just kind of shows you the flow of information minus the connection here to the local health department, and that's really the only thing missing, and I wanted you to be able to have that slide. We are still refining this. We set this up in less than 30 days, and we're not even 30 days into it now. We are making sure that our text and emails offer the option of Spanish, and we also are offering in the near future 2 Burmese dialects that we have, and probably further dialects that may be needed. We're allowing the local health departments now to engage with the MS Dynamics platform so that they can see that, and in the very near future, if they would get this information before we do, they will actually be able to initiate the case itself in MS Dynamics, which is incredibly important so that we can get all of this documented and in place as soon as possible. We're really proud of the work that we've been able to do in a very short time, and I thank you for the opportunity to be able to share that with you today.
Excellent. Thank you so much, Dr. Box, for sharing that incredible information. Now I am pleased to introduce our final speaker, Dr. Monica Burrell, the Commissioner of the Massachusetts Department of Public Health. Dr. Burrell has practiced general internal medicine for more than 20 years and has been a commissioner for more than 5 years. Welcome, Dr. Burrell.
Thank you so much. And thank you so much for having me here. It's wonderful to be here with Dr. Shah and Dr. Box and Iris. And my comments really fold in nicely to many of the comments that they made around contact tracing and testing. And I won't repeat what they said in the interest of time, but I want to focus our discussion on some of the particular ways in which we are addressing the COVID-19 pandemic in Massachusetts. And even though we're focused on testing and tracing, it fits in a continuum of how we look at COVID-19. So I'll address some of those features as well. And the most important thing to take away from my part of the discussion is embedding our decision-making, our planning, our contact tracing plans, and our testing in data. So that has been a real focus for us, is in this area of an evolving disease where new information is learned every day. From where I sit and from where our audience sits, there's so much decision-making that needs to be made now in a gray zone as we learn more about the disease. Having as much data as we can at our local, state level has been critical for us. So these are some of our key features of our COVID-19 response in Massachusetts, and I'll go through a few of them quickly to give you just a flavor of some of our work here. I spoke to you about data, and I'll give you an example of our data dashboard as well. We have spent a lot of energy putting together our daily data dashboard. That comes out every day at 4 p.m. If you're interested in seeing it, you can go to mass.gov/COVID-19 or just our mass.gov website, and you can see every day this data is updated and includes, as you can see here, cases, testing, cases broken down by hospital, county, other demographics, as well as hospitalizations, deaths, and our hospital capacity and census. In addition to that, every week on Wednesday, we put out information that is stratified in other ways, including by city and town, deaths that we're seeing in long-term care facilities. Several of the speakers who went before me spoke about the high risk of these congregate settings, and other pieces such as individuals who were released from isolation, often defined as recovered, and our PPE distribution. You know, as I look back at the work that we've been doing and reflecting back to the beginning of February, where we became the first state on the East Coast to have an individual with COVID-19, really it's been about being able to put this information out and really make sure that, as other speakers have said, that we are looking for protecting the most vulnerable individuals, and I'll go through some of that data in a minute, as well as making sure that our healthcare system can address any surge that may occur. And what you'll see here in this slide is it's just a sample for you to get a sense of daily information that we continue to track and was very useful for us during our surge capacity that we witnessed in Massachusetts in the month of April. And this looks at our alternative medical sites, ICU and non-ICU beds, and occupation rates, so that we, throughout, on the left, you'll see total for Massachusetts, and then broken down by different regions within Massachusetts. And we had daily reporting in to us at the Department of Public Health so that we could very closely monitor the capacity within our hospital and healthcare systems. And as a reminder, this is very important to us as we were one of the states that witnessed, unfortunately, a very high number of cases. And this is just to give you a visual of one of our surge sites, the Boston Convention and Exhibition Center, where we had set up over 1,000 beds in order to have the capacity. We were fortunately, with our social distancing and other measures we put in, we did not have to use much of this alternate capacity, but had it in place in case the surge demanded it. There's been several of our speakers have spoken about the focus on long-term care. We had several, as we became aware of the increased needs within our long-term care facilities and the higher risk of our long-term care residents, we put in place a plan with 6 key initiatives, and that included increasing the testing capacity. And for that, we did our own testing, but we partnered through mobile testing programs where individuals can be sent out to their long-term care facility, including our colleagues at the National Guard doing their testing, and then it being run back either at our Department of Public Health lab or our reference lab at the Broad Institute. We also worked very closely with our long-term care facilities to distribute personal protective equipment, which our colleagues in the hospital system were very used to using, but not as much in the long-term care facility. We helped with supplementing through our medical reserve, National Guard, and other places, staffing and needs for staffing, especially as some staff also became positive and had to be out in either isolation or quarantine. Additionally, we put more funds towards dedicated work in COVID-19 skilled nursing facilities, and also throughout our long-term care facilities, really with a focus on enhanced infection control and training. Talking for a minute about our testing and tracing capacities. So we, in February, when the CDC allowed for state public health labs to be able to validate and run their own tests at the end of February, we began to do that. As the criteria at the federal level loosened in terms of who could get tested, we expanded our testing further and now have sites across the Commonwealth of Massachusetts that are doing testing both at hospital-based, community health centers, pop-up sites, mobile, et cetera. And that is, the focus of that is really about testing individuals, both, by the way, who are symptomatic and who had exposure, tracing who the individuals are, and then supporting, especially this part is very important, as we work to isolate and quarantine. As many individuals talk about across the country, there were some individuals who needed further assistance in being able to isolate and quarantine. And I'll talk about that a little bit more in a few slides. You saw this, so I won't spend too much time on this, but you heard a little bit about the workforce. I will say that in Massachusetts, our local boards of health had over 1,000 individuals already doing contact tracing and case investigation. As a couple of people mentioned in the chat, this is a 101 function of public health. But what happened here is that because of the volume, we needed to increase our capacity to do the case investigation and the contact tracing. And for that, we partnered with Partners in Health, which you heard about earlier, to form a community tracing collaborative. And they were then quickly able to hire and increase the number of tracers we had to 1,400 from them and 1,000 from our local boards of health. And additionally, we had public health students working with us. An important feature that I want to point out that hasn't been mentioned yet is in this area of care resource coordinator. And that is someone with a social work, nursing, or equivalent degree who can help individuals who have social needs or social determinants of health that make it challenging for them to be able to isolate or quarantine, and connecting them to resources. And that's been a really important part from my point of view to ensure that everyone who needs to can do appropriate isolation and quarantine. And in the same way, keeping the work local, we have used local boards of health to connect to high-risk communities and individuals that they would know, and that information is kept at the local board of health level. Communication has been key for us. You'll see here just some examples of highway billboards that are around how we each individually can participate in saving lives related to COVID-19, social isolation, face coverings, and the like. We also, there's a question earlier about contacting individuals and whether they would pick up the phone, and we developed a caller ID called Mass COVID Team so that individuals could know that that's who's calling them, and we related to that did a mass communication campaign so individuals could know about that as well. I want to just now walk you through our most recent data dashboard. I'll just spend 2 minutes on this so you can get a flavor of what kind of information we're putting out publicly and how it's helping in our continued work in Massachusetts. As I mentioned, in April we had our surge. We stayed at that surge peak for several weeks, and thankfully are now on the other side of our flattened curve, if you will, and are focused on reopening in a way that follows public health metrics. What you'll see here on the left-hand side is the measures that we use in order to see where we are within our reopening process that began on May 18th. And on this next slide, I want to show information that we share every day, looking at confirmed and probable cases of COVID-19 and broken up according to the cases we've had. So just to give you a sense of the burden of our disease here in Massachusetts, we have had over 100,000 confirmed and probable cases. This next slide is very important to us as part of our reopening strategy here in Massachusetts. And you can see here that we follow several important pieces of information, including the one that Dr. Shah mentioned about positive molecular tests, or that PCR. So that point he made is a really critical one, that for all of us, one of the most important things we can do is continue to have increased testing capacity, testing more individuals, but seeing the percent that are positive come down. And here in Massachusetts, we've been below, he used 3%, we use 5% consistently, and that's been a strong indicator and something we watch closely as we reopen parts of our economy. And then, as I mentioned earlier, it's very important to us that our hospitals and healthcare system can manage the number of individuals admitted and any potential surge capacity, so we track that very closely. These next few slides show you again what we share every day, and I welcome you to our site to take a look. This is looking at confirmed and probable cases. This is looking at the testing capacity, where on average we're testing 8,000 to 10,000 individuals a day. This is looking at our deaths so that we can track that very closely. There's been some discussion on the chat and questions that came up earlier about who's at increased risk, and we very closely are looking at data in different ways. So this here includes breaking up the number of cases by age groups, and if you look on the right-hand side, you'll see that the rate of individual cases, the average age is in the 50s of people who come back positive. And this next slide is the average age of people who require hospitalization. And you can see now the age has gone up to 68. And then this slide shows that unfortunately the average age of death, we see that this is really predominantly individuals who are older. And as we look at our reopening, we're very carefully looking at who is at increased risk, including older individuals, to have them take additional precautions. We publish a lot of data related to our long-term care facilities, where unfortunately we still see about 60% of the cases. We report on individuals related to their whether they get hospitalized, and as well as whether they have underlying conditions. You'll see all the way on the right that the vast majority have underlying conditions. My colleague Lisa Pellegrino from Massachusetts asked about obesity, and morbid obesity is one of the underlying conditions, as well as other heart conditions and respiratory conditions. And I'll just pause here to talk about race and ethnicity in this particular moment in time. It's been very important for us to be able to capture cases, hospitalizations, and deaths by race and ethnicity. And unfortunately, we see here in Massachusetts, I know this has been replicated in other parts of the country, that Black non-Hispanics and Hispanics have 3 times the higher rate of positive cases than white non-Hispanics, over 2 times hospitalizations, and also higher rates of death. So we're working with this data to additionally look with our Health Equity Advisory Group on the racial and ethnic disparities that have come out related to COVID-19 and doing further work in that. And I thank you very much for that. I know we had to rush through this because we're at the end of the time, but I am happy to talk with anybody else offline, and really appreciate the time and the work that you all are doing as well. I'll hand it back to Tara.
Excellent. Thank you so much, Dr. Burrell. Really appreciate your presentation there. We are going to just open up for a couple of questions, and I know we'll be going over. We're just at about time here. But I do want to get to one question that came through the chat for you, Dr. Burrell, and then also one that we've been getting from our members. The first one through the chat box is, do you collect data electronically at your testing sites? And then the second question is, could you talk about how you're funding some of the testing and contact tracing?
Absolutely. So thank you for the question. So our reporting is almost all coming in electronically. So we have an electronic lab reporting system, and we have a Massachusetts epidemiological tracking system that is all electronic. I will say that not all pieces of the information, depending on where we receive it from, is able to be placed in electronically. And one of the things that we're working on is being able to have the entire system be electronic. As many of you know, public health has still been using, paper and faxing in many cases. And for most of our infectious diseases, the numbers are low. If you think of things like tuberculosis and measles, the numbers are relatively low. But if you look at now the numbers we're seeing, you saw that I talked to you about 100,000 cases. We really are working more and more to become electronic. The short answer to our funding question is that our funding is a mix of state and federal funds that have been put specifically towards COVID-19.
Excellent. Thank you so much, Dr. Burrell. Thank you again to all of our presenters for sharing their time and expertise on today's webinar. I do want to point out the resources that we have under the resource tab. In addition to national guidance and resources, you'll find NCSL's most recent publications, including our COVID-19 legislative tracking database, which as of today includes over 2,000 bills introduced in state legislatures related to COVID. We also have several memos and blogs on testing and contact tracing. You can also find links to private industry resources and developments on testing and contact tracing in the resources section. In the next few days, we will post the recording and the slides on our webpage. This concludes our webinar for today. Thank you all for your participation and stay well.